Good morning, I'm Dr. Aisha from MMI MSR, Mulana. In this case, we are presenting you a case of 70-year male with a BMI of 30 posted for supraumbilical hernia repair. Here, as you can see, we are performing a segmental thoracic spinal with a thoracic epidural in situ. The technique used here is a bit different as we have advanced the Quincke needle till ligamentum flavum. Now, as the ligamentum flavum is pierced, we are removing the stilette and the spinal needle is advanced alone. The spinal needle is advanced till the CSF is seen. This technique never fails and we avoid spinal puncture and the needle never gets blocked, and it is easier to do as compared to the other technique. Now, as the CSF comes, we are giving segmental spinal at T8-9 level using 1.5 ml of 0.75% isobaric ropivacaine and 0.5 ml of 0.5% bupivacaine heavy with a 25 mics of fentanyl in separate syringes. Now, why separate syringes? So that we do not change the baricity of these two drugs. As you can see, we have aspirated and now we are giving the second drug, that was 0.5% of bupivacaine heavy and a mixture mixed with 25 micrograms of fentanyl. Now our spinal and thoracic epidural are secured and we are giving the patient the position. The surgery has started. Now, something about this case, why we have given the patient segmental spinal. This patient was a known case of bronchial asthma on regular medication. His stop band score was 3/8 and his MET score was less than 4. His hemodynamics were maintained and cardiac evaluation was unremarkable. However, our patient had dyspnea on talking and his roommate saturation was 83% and on ABG his PO2 level were 52. We discussed this case with the surgeons and decided to take this case under subarachnoid block, but our only limitation was duration of surgery. Thus, we decided upon thoracic epidural with a thoracic segmental spinal. Now, why segmental spinal? Surgeries that cannot be done under conventional spinal, such as this surgery, a higher level of block can be achieved by smaller doses of drug, which means there will be less hemodynamic fluctuations, early recovery, and it is advantageous in patients with existing respiratory comorbidities, and there is less incidence of post-op nausea and vomiting. As for the choice of drugs we have given in segmental spinal, we have used a 0.75% of isobaric ropivacaine. Since they are not position dependent for spreading intrathecally, patient can be placed directly in operating position and spinal can be given. During combined spinal epidurals, drug can be given before placing epidural. It causes less hemodynamic fluctuation and it causes less motor block, leading to only early recovery and early ambulation. In our case, after giving thoracic segmental spinal, we achieved a level till T4, since the incision was anticipated to extend till the level of T8 and for the fear of peritoneal stretch, which might have been uncomfortable for the patient. We kept infusion noradrenaline on standby in case patient had any hemodynamic instability. This kind of pre-handed preparation and planning is important when practicing procedures like segmental spinal, which we have not yet registered at our spinal level and are still in learning phases. However, in our case, as you can see, our patient was hemodynamically stable throughout the surgery. His blood pressure and heart rate were maintained. The surgery was done flawlessly by our surgeons, and in post-operative period, the patient was comfortable and moving all his 4 limbs, and the patient had a good cough reflex. As you can see here, the patient is moving all his 4 limbs and the level he was having was still at T4.
पैर हिलाओ, खाली पैर हिला रहे थे ना, हिलाओ। हाँ बढ़िया। दर्द नहीं है?
तुम छोड़ दो।
जोर से हिलाओ, थोड़ी से। ठीक है बाबा, आप सांस लेने में दिक्कत तो नहीं हो रही? बस अब आराम से बैठो।
चलो